Joel McCullough, Spokane Regional Health District.
Keith Baldwin, appointed citizen.
Shirley O'Quinn, Spokane County.
Amber Waldriff, City of Spokane.
Mike Fagan, City of Spokane.
Ann Fitznagle, Recording Secretary.
Michelle Fossum, Legal Counsel.
Susan Norwood, appointed member.
John Snyder, City of Spokane.
Chuck Hafner, City of Spokane Valley and Chair.
Kevin Freeman, Vice Chair, City of Millwood and representing small cities.
Okay, as you realize, there are a number of people absent today, so I would have a unanimous vote to excuse them at this point in time, please. All those in favor? Thank you. That's my Santa Claus excuse for the day. Okay, let's go for citizen input, please. Oh, Mike?
Before we go any further, just a courtesy notification. I am going to be needed at an alternate meeting here, so I'm going to have to leave at 1:30.
1:30, okay, thank you.
Request if there is anything that's important that needs to be voted on, that we take care of that almost immediately. Thank you.
Okay, thank you, Mike. We do have one citizen request to speak today. So, Catherine, would you mind coming up to the podium, please? We allow 3 minutes for your presentation, and thank you very much for being here.
Hi, my name is Katharine Isabelle, and I have lived in Spokane for the past 6 years. And for the past 6 years, I had to inhale. I had to inhale air from people warming up their cars, especially in winter, for 5, 10, 20. I have timed as much as 30 minutes. Boom boxes is another issue. I've written a letter to Dr. McCullough on August 19th, 2013, which is over a year ago. I have never received an answer about that, and I put some of these issues I'm talking about in that letter, and I think this is the least somebody can expect who lives here, that a letter is responded. And from my experience, no matter whom one contacts in this community, either by fax, by phone, by letter, no one really has the courtesy to respond. And I want to make this public today because I'm tired of it. I also enclosed information about hearing loss association, especially with children. These boom boxes, day and night, I wake up. I don't live on a main street, but I wake up in the middle of the night because people are racing through Rowan and have their boom boxes blasting even in the middle of the night. And the air pollution is, of course, another system. Nothing is enforced here, which, of course, is not your job. It is the police's job, and they don't do their job here. Nothing is enforced here. Not the boom boxes, the racing, violation of the laws and the ordinances and codes. Nothing is enforced. So when do people in this community get together and finally say, enough is enough? I have lived here 6 years. I hope to move out here because I'm sick and tired living in the city. And your secretary maybe is making copies of the letter I wrote to Dr. McCullough more than a year ago.
Okay. Thank you very much.
Do you have any questions?
Thank you very much.
No questions? Too bad that nobody else is showing up, considering that you have 200,000 people.
We will relate to your concerns. Thank you very much. Item number 4 in the chair report today. First of all, there's a couple things I'd like to mention is the preparedness that the health district has had regarding the Ebola situation. I think they have informed us time and time again of what's happening, what's going on. They have a preparation team that's all ready in case we need it. So, Dr. Joel, I just want to say thank you and some kudos in regards to you and your staff for that preparation. I was able to relate that same type of process that you're involved with the City of Spokane Valley Council, and they also were very appreciative of knowing what was going on and what's happening relative to the Ebola portion of it. So again, I thank you very much. I do also want to make sure that you understand that Mayor Freeman has been reappointed as the small cities representative for us. So I want to congratulate you, Kevin. I know you're exactly thrilled about that. And so if you think this last year was an easy one, you're mistaken what 2015 is going to give you. So also, we want to talk a little bit about the strategic planning update. And I think Mayor Freeman and I think that Linda, are you going to be the lead person, Linda?
Well, he just pointed at me, so I think so.
Linda's going to be the lead person, and I'll chime in.
Okay. Thank you very much.
Yeah, thank you. I just give you a quick update of where we're at in the process. We're nearing completion. We've been working a little bit late last summer, but mostly starting in September with a work group of interdivisional staff as well as 3 of your board members, and also coordinating the work with our executive team, our executive leadership team. We've had several meetings with our consultant facilitating those efforts, 2 very significant staff engagement opportunities, and brought everything together, and I think we're now at the point of a pretty solid draft. Our work group is meeting next Monday to finalize that and then send a recommendation to the executive team, which will happen in mid-December. And I think we're still on track to bring it to you in January. So that's where we're at.
I was just going to say, as being present at those meetings, I have to compliment Linda and the consultant and the work group staff for bringing back a number of concerns from those outreach efforts to staff in general, and they've done a fantastic job of really working that plan, working the strategic plan, incorporating the staff's concerns, and refining the document. I have to say that's pretty much over the last couple meetings, it's been very much a living document, and there's been a lot of thought and effort put into it by the SHRD.
Yeah, and I think the work group has put in a tremendous number of hours, and really appreciate all the work they did. They were the ones who really facilitated the staff input outside of our regular meetings, and we're down now. We have 4 goals. 2 are focused a little bit more internal, 2 on kind of some special projects and special efforts. And we now have then strategies and very specific action items that we will be developing plans for, so we make sure we actually get those implemented over the next couple of years.
And I would like to add, it's just unbelievable to me the amount of time and effort you put forth, Linda, in organizing this whole strategic planning, and it's very satisfying for us as a board to realize that the effort that staff is putting forward in order for us to move forward. So again, thank you very much.
You're very welcome. Thank you.
Keith, would you like to say something about the governance committee? In your packet, board, you have the results, the final report of the governance committee that we met. I'm sure that you'll discover there's many items, what we've gone through and what we've done, and also what we're going to do in the future in 2015. And I thought that Keith was the chair of that particular committee, and I thought perhaps you might like to say something, Keith.
Yeah, I'm always up for saying something, Chuck. But no, I'm not going to repeat everything that went in here. I would like to say just a couple of things, though. That the people who were involved and participated, I thought we had some great discussions, which really helped all of us learn a lot more about public health and how we govern public health. So for those of us who got to do that, I thought it was really a benefit. For those who didn't, we hope to sort of bring you along over time through the work of the Education Committee, as well as other work that we do in the future. And we really feel like this Governance Committee finished their work, although Chuck was pretty adamant that we needed to do sort of a quarterly check-in and see how we're progressing, especially for those people who didn't get to participate in the actual discussions at the Governance Committee. So I think in addition to what you see on paper here, I think the discussion was probably some of the best benefit we had out of the group, and the ability to be transparent about how we wanted to move forward. So with that, I should thank Linda, who actually did all the work, and we just got to come and sort of respond. So it was great, though, and I appreciate the opportunity to have worked with the Governance Committee. Thanks,
Perhaps
Chuck.
I'll add one thing there. One of the discussion items we had was those of us that are elected and on so many different boards. And, people think that because we're elected, we're on a health board, or we're on an STA board, or we're on the 911 board, or other boards, that we all of a sudden become an expert in whatever is happening in that particular agencies. And I think we had a very thorough discussion that that's not possible. We have to rely on the experts, and that's Dr. Joel and his staff and his people, and Torney and so forth, because they're the experts. And I kiddingly said that when we can't believe in them, then we're in trouble. So thank goodness we can believe in them. But here again, it's a matter of trying to mesh the two together philosophically, and what we can do in providing policies that best fit that umbrella that the health district can work under. So it was a very, very good committee, and thank you, Keith and Linda, for doing that. And it's going to be make it very possible for us next year to again completely move forward in that. And I as the chair this year, I appreciated that very much.
Mr.
Yes,
Chair.
Amber.
Oh, I just wanted to comment that I really appreciate all the work of the members of this committee, and I hope you'll bring me along. But I think you guys did an amazing job. I thank you for your leadership, Keith, and of course for the staff support. But I love to see a committee where you have a huge list of accomplishments, because that makes you feel like your time and efforts were well spent. And so I appreciate that you really had a focus on outcomes that would benefit the board and the community. So thank you very much.
It was a little bit of work at times, but we got through it.
Any other comments?
I think the only thing else I'd add is I loved how this committee was set up, and that we had a beginning and end. And I know that there's a check-in point, but I know that I'm not a big fan of sitting on all these other boards that then have mandatory monthly committees that just meet to meet. And so just kudos to you guys for creating a committee that had a specific purpose. We could jump in, roll up our sleeves, work at it, and then it ends and we can dive into the next thing. I think it's more productive of our time. So I like this setup much better than the ongoing committee meetings.
And I think the other thing, that one of our purposes was to make sure that we try in every way to have board members involved in some aspect of the health district, because that way they get to know the personnel so much better by doing that. And so we'll continue in that particular vein. Any other comments anybody might have? Okay, thank you very much. Okay, Dr. Joel, Health Officer report, please.
Good afternoon. I have a couple of brief items today to discuss before the board. The first thing I would like to talk about is another update of the Ebola situation. As you know, the current Ebola outbreak in West Africa is the largest Ebola outbreak we've ever seen, and it still remains centered around the three affected countries of Guinea, Liberia, and Sierra Leone. Excuse me. And at this point, there are over 17,000 cases and over 6,000 deaths. Over the last several weeks, there have been some degree of slowing in Guinea and Liberia, but transmission remains pretty intense in Sierra Leone. In terms of the countries with localized transmission, there are two. One is United States with 4 cases that were diagnosed here. And since the last time we met, Mali has joined the list of countries with localized transmission. And they currently have a case count of 8 cases and 6 deaths. There's been no recent cases in the United States since the ER doctor in New York was diagnosed. And as I mentioned earlier, all returning travelers to the United States are identified and monitored in their local communities for 21 days, the incubation period of Ebola. I sent out, as Councilmember Hafner mentioned, I did send out to the board a notice that here internally we have instituted our incident command system, mainly to assist in communication and coordination of our activities, and that remains in place. However, we have decreased the meeting time frame from to every other week. And also, another update is that currently there appears to be, in terms of monitoring, 16 civilian individuals in Washington State and 16 military individuals being monitored, mostly on the west side of the state. We have no one being monitored here in Spokane County. You probably saw earlier this week that the CDC identified 35 Ebola treatment centers. And the purpose of these Ebola treatment centers are to provide comprehensive care for persons diagnosed with Ebola, and obviously to provide protection to the staff who are providing care. And these 35s were informed by CDC site visits. The CDC went to the hospitals, determined if they had appropriate systems and knowledge to be a treatment center. Currently, none of the 35 treatment centers are in Washington State. However, Washington State has identified 8 hospitals that will be termed Ebola ready. And next Thursday, CDC will come to Washington State and to Spokane to provide some technical assistance to Sacred Heart in terms of their Ebola preparedness efforts. So I will be present, and another staff will be present for that as well. So that is my Ebola update. Finally, I'd like to call the board's attention to this document, Linking Transportation Planning and Health. This report was created by our data center and in partnership with the Healthy Communities program here at the Health District. And the purpose is to highlight the connection between transportation and health impacts. The Healthy Communities staff will use this report to educate decision makers and residents on the health benefits of multimodal transportation infrastructure. In the spring of next year, they'll also partner with the Inland Empire section of the American Planning Association and host a local conference on health and transportation, where this report will be highlighted. And the report will also have an equity focus. This is the follow-up conference to the transportation symposium that we held here locally in the fall of 2013 that many of you board members did attend. So that's all I have for you today. Are there any questions?
Any questions, Dr. Joel?
Thank you.
Okay, thank you very much, Dr. Joel. Okay, I think what I'm going to do is, in order for Mike needs to leave, I would like to take 8C and move it up prior to the legislative report by Linda. So if you please look at item number 8C, resolution number 14-08, adoption of the WSNAMO contract. And also at the same time, when we complete that, I'd like to have a separate motion to provide Dr. Joel, who is not included in this resolution for the COLA, so we can move forward with that. So at this time, I think that Torney and Barbara will give us an update, please, on resolution number 14-08.
Okay. So as you recall, we met with you in July prior to negotiations with both of our unions, and you gave us some parameters on how much we could spend on cost of living increases and increased contribution rates to benefits. So we concluded those negotiations in October, and they were taken out to vote by the unions and agreed upon. And so what you see before you is a resolution that reflects that. So
in our negotiations, we have stayed within the parameters that you set for us. So we have done so, and it was already included in the budget that has been passed. So today we're asking for support of this.
Move approval of that.
Second.
Okay. Any questions regarding that for Torney and Barb while they're up there, please? Okay. All those in favor, signify by the raise.
I don't. Sorry, I don't have a question. I have a comment.
Okay.
just because I have to vote no for it, and I mean, for the record, the reason that I'd have to vote no is because we have not been able to give county employees a COLA increase. Next year will be the 5th year, and we do contribute $2.7 million towards the health district, and so it is therefore perceived that we are part of funding the COLA here, and so because I can't offer the same thing for my own employees, I can't vote to support this. So,
okay. Well,
that's
thank you.
for the
Any other
record.
comments? Okay. All those in favor?
Aye.
Those against? Motion is passed.
Against.
Also, at this time, I'd like a motion to provide a COLA of the same amount that we did for the employees for Dr. Joel, and I'd like to have that in the motion form, please. Amber, would you like to give that motion? We have to have a separate motion, or we can go into executive session if this board wishes to. But we had discussed that, if you'll recall, that Dr. Lutz provided that same information to us when we were in executive session. Oh gosh, what was it?
Okay, I had a different memory of what we had discussed, but if someone else would like to make the motion.
I'll make the motion.
Any second? Second. Okay. Now for discussion, please.
Yes. Yeah, I'd like to find out what your perception was of that.
That can be in the
Yeah, I think I
executive
have
session.
to do it in executive session.
But I have the same memory Amber does on this item.
Well, we can certainly go into executive
Related to
session,
it.
discuss it if this board feels necessary to do that. So,
Well, Mr. Chair, I think it would be beneficial to all of the board members here if we ended up doing that. I mean, if for no other reason, as a reminder or refresher as to
Right, and I
what
may
was
have a wrong memory, but I thought we had discussed, not decided about anything, but had discussed some other
okay.
options.
Okay, Michelle, can we go into executive session at this point in time, or what?
Well, the only reason that we go into executive session is to discuss performance or you need legal advice of some sort. Those would be our options.
I think it was related to the performance of it. If I'm thinking what she's thinking, it was related to the performance of the public employee, not the actual COLA. Because we didn't discuss the COLA in our last meeting. It was performance related.
So to the extent you want to,
And that being the case, we could do that at this time?
we can do that at this time under 4231
Okay.
How long do you think we need?
Well, let's go 15 minutes. We need more than that. We can come down and get more time. But I don't think we're going to. Sure. Okay. So at this time, I'd like everyone except board members, if you would like to go out and in the commons area, please. We'd appreciate that. Make it on the record that we call the executive out of session at 1:20, please.
So, Chair, at your request, I'm going to withdraw my motion and allow us to consider this in January. There's some confusion over this, and we have key people who aren't here today. And given that, I know where I stand on the motion, but given the fact that we have some confusion and we have key personnel missing, I'll withdraw my motion for reconsideration in January.
Okay.
So, but it can't be withdrawn without the second.
Where's the second? Who seconded?
Second.
Okay. You withdraw your second? Okay, that's withdrawn, so that you're recommending, do you want to make that into a motion now?
Okay, so I guess I would make if you'd like, I would make a further motion that we revisit the health officer compensation vote in January and have that added to the January agenda.
I'll second.
Okay. Did you second it, Shelley?
I did.
Okay, any further discussion? Mike?
Yes, sir. Just a clarification. We're talking, I think we need to be real specific in the motion as to what it is that we're talking about. It's either a COLA, a step increase, a merit pay increase. What is it that we're actually talking about?
I would say we're talking about two things. We're going to talk about the COLA increase and potential merit increase. Potential COLA increase, potential merit increase. There's confusion about that today, so we're going to put both of those on the agenda for January.
So that's the intent of your motion?
Yep.
Shelley, do you agree with the second in regards to now you have a definition of the motion?
Yes.
Okay, any further discussion now? All those in favor?
Aye.
Those against? It has passed. Thank you, Mike. You have 17 minutes. You can go. Okay. Let's go back to the legislative report. Linda, please.
Okay, hello again. So the goal for today is we really want to try and agree on a Board of Health legislative agenda. As you know, we sent out a request for you to all kind of rank the budget items and the policy items. And the goal of this was not to come to some absolute ranking. It was to get a sense of where there seems to be some consistency and consensus among you and where there is not. So that today we might focus on where there seems to be quite a wide array of opinions. This is not an absolutely scientifically perfect data analysis. I did not hear from everybody, so that's one limitation. Also, there was a little bit of reinterpretation of the instructions by some folks. So the way information was given was not consistent. But we still got some useful information out of it. So I'll show you that. But I do want to remind you, we're not here to try and rank your priorities. It's really trying to just to help figure out what seems to be in and what you need to talk about some more. Does that sound good? So if we could start with the budget issues. The foundational services really consistently ranked pretty high, and I would like to come back to why it's now crossed off. The communicable disease funding and the BRFIS survey were kind of that next tier when it came to budget issues. And then rankings of recreational marijuana and transportation revenue package were from 1 to 5. So thought you might want to talk about those two a little bit further. In regards to foundational services, we've talked about this a little bit. This has been a project that's been going on statewide for a couple of years now, at least. Really trying to identify those foundational services that every public health jurisdiction should be providing, figuring out what the gaps in funding are, and then determining what the ask of the state should be to fill that gap. That work has lately gone into a policy committee where they were really trying to get very specific. Okay, what is our ask on this? That work is still going on. There's still a little bit of disagreement about some of the foundational services. Also, some real discussion around what's the ask and how do we message this and how do we talk about this, because there's foundational services, there's a second tier of additional services, and then there's also this current pot of money, which I'll talk about in a second. And there needs to be a very clear message and ask around that, and they haven't had time. And there needs to be a lot of discussion outside the legislative session to make that happen. So that big effort is being put on hold. The focus is going to be on the communicable disease funding, because in that foundational work, that was found to be one of the services with the biggest gap in funding. John Weisman, Secretary of Department of Health, is moving forward with that as the big ask. So in addition to that, what I'm recommending is that these seem very clearly to be on your agenda. I think you might want to spend a couple minutes talking about, do these stay on, or is there a need to take them off for any reason? And then I'd like you to consider this last item, and it relates to the overall public health budget. It's the public health assistance account. This is funding that used to be in 3 separate streams that came to us. It was since, in the last year, 2 years, consolidated into one stream of funding. It's pretty flexible money that comes to us. The reason it wasn't up here initially was that part of the discussion about foundational services was core foundational services, additional services, but don't take away this money. So I didn't have it spelled out separately, but now because we're not having the entire discussion about foundational services, I think we might want to add this. It's on WSALFA's agenda to make sure that that money stays there. That money is in the 1/3 of the state budget that is not required by the Constitution or under federal regulations. So if the state needs money for some other purpose, they could pull it. So, or at least cut it. So I think we might want to have that on our agenda. So discussion on budget issues, and then when we get there, we can go to policy. Shelley?
Just the one item that I had spoke to you about for transportation.
The revenue package one? Yeah.
Yeah. So transportation revenue package was that I feel like the description needs to be expanded to include the north-south corridor. And if you look at even your report that you handed out, linking health to transportation, I mean, the north-south corridor is going to reduce, it's going to take traffic off of Division, which is 29 stoplights, and turn a 30 to 45-minute commute into 12. I mean, so you take all the idling off the roads, so all those particulates that, all the other reasons it includes, the pedestrian, bike and walk path, and it's the number one transportation priority for our community. So if we're going to support the transportation revenue package that includes safe routes to schools, complete streets, active transportation options, et cetera, I just would recommend that we include the number one project in this community that also meets most of your transportation health-related outcomes.
Okay. Other thoughts on that?
I'd agree with that.
Anybody not agree?
From the Millwood standpoint, from rail safety issues, I think we'd also like to see some renewed support and emphasis for bridging the valley. Removing those rail crossings, putting the bridge back in, some things that would alleviate some of the other rail traffic, consolidate the UP line onto the BN line.
You're not going to like that 100 trains coming through Millwood every day?
We don't like it now.
So I think I could come up with a bunch of other projects that are also road projects that you could assert have safety impacts, and we could list probably a couple dozen of them in Spokane County. Not that the north-south corridor or bridging the valley don't have some great reasons to be on there. So I would either like to add them all in or just scrape that descriptive language completely, and maybe we don't have any descriptive language after that one, or just take it off as a budget priority, because I think we need to really focus on the most direct health impacts here, and I feel like we're kind of drifting away from that if we start putting so many road projects on the list.
But if we're not specific, then it doesn't remind the legislature of what we really want. I think we can get too general sometimes, and
See,
that's my opinion.
I would personally agree with part of your statement when we said pull it off, because I do think it's starting to stretch. If, because of the other initiatives that you have on there, you want to include transportation, we're actively out there supporting a transportation package, but it just needs to be, if we're going to describe it, I guess I just personally feel like it needs to support the number one transportation project in our region.
I just want to be really clear that there's very few things that are as tied as closely to public health in my mind on this list as transportation, especially in our county. But the reason I would agree with Commissioner O'Quinn is for a completely different reason, and that is one of our criteria for keeping things on the list is their potential to get passed. And right now, we don't have a single Republican legislator in Spokane County being in favor of a gas tax. Without that, bridging the valley, north-south corridor, the West Plains Geiger interchange that City of Spokane is pretty invested in, none of those things are going to happen. There's just no way. So I would advocate keeping it off, not because there's not a close nexus with public health, but I think as we see a few different things continue to evolve in the legislature, the possibility of a transportation package seems to keep getting lower and lower, and maybe that's the reason it should come off.
And that is part of the criteria.
Any other comments from anyone else?
Yeah, I'll just note that is part of the criteria, and I think the reason we started off with it limited to those programs that we had it limited to was because that direct tie to programs we have here, which is another one of those criteria. So that's why it started that small. But again, if one of the criteria has to do with feasibility of passage. So,
Well, moving this along, can both the concepts we put forth, what we're looking at between John and Shelley, if nobody else has any concerns?
Mike, did I see your hand?
Yeah, I did have my hand up. I mean, I would definitely be a proponent for taking it off there also, because I'm not supportive of a tax revenue package. I believe that we can get our north-south freeway taken care of through reprioritization, reform with WashDOT, and things to that effect.
So how about this?
And I am being consistent with my position as City of Spokane council member also.
Okay.
So how about this? Let's remove it, and then if Linda, if there's opportunity on, say, a Safe Routes to School or funding becomes getting a lot of momentum, we still have the opportunity to write a specific letter on something like that at a later date. So I would make a motion to pull off the transportation revenue package from the budget priorities.
I'll second.
Okay, any further discussion? All those in favor?
Aye.
Okay.
Okay. Recreational marijuana, again, on this one, the focus is really on just protecting the funding that's in there to go to healthy use survey, research, and prevention and education efforts. So would like to know if you want that on there, and same with the public health assistance account.
I think I have one question on this. I know that in our discussions at the county, we've been talking about, I know that the Washington Association of Counties has been working with the Washington Association of Cities to come up with a proposal for the split for revenue taxes from marijuana. And I think they've come to an agreement on what that split would look like. But I believe that they're asking that description being, or the use of that be expanded to include public safety items. And I don't know if this is going against what both the Washington Association of Cities and Counties is.
John, you have a committee that's working in that, do you not?
Yeah, and
I'm asking it as a question because
No.
I want to make sure we're not
I don't
supporting
think we
something
are.
that's going against.
So let's read the language. Protect or increase current revenue allocations for education prevention efforts, research, evaluation, and healthy youth survey. Other than the healthy youth survey, all those other items are required in the initiative. Now, there only takes a simple majority to change the initiative. What we're asking for there is don't mess with those basic requirements.
Okay, but we're not saying that we don't support it for public safety.
Oh, not at all. I think we're smart to sidestep that discussion because I think the local revenue, the public safety revenue is going to be more controversial and it's going to be a lot of back and forth on. I think it seems prudent to me that we just narrow it to what we have here and just say we want to make sure you don't touch those funds.
And I was asking it as a question because what I didn't want us to do was to adopt something that was then going against what we're trying to do on the city-county side.
Right.
So
Understood. But we're looking for that revenue too.
Right. It was just clarification. Thank you.
And the issue is that there's going to be a lot of requests for changes seeking some portion of the revenue, so it really is just protecting this part. So comfortable keeping that on?
Thanks, Mike. Merry Christmas. Okay, Amber.
Yes, we do. Okay.
I think that I totally support the public health assistant account. I guess I assumed when you had the listing of foundational public health services, I was assuming that's what you meant.
It was,
that we would support that ongoing stream that comes from the state to here. So if that's a better way of putting it on our on our agenda so that the legislators understand what we're talking about, then
it's separate but related issues. Foundational services, which much bigger than that, a much bigger issue, whole different sort of
But
message
this is
around
the
that.
actual
But this was
dollars.
This is the existing.
Yeah.
Foundational services was really focused on asking for more and protecting this.
Okay.
So.
Well, I support specifically pulling that out and putting it in our budget issues.
Does that clarify it for you?
Yeah, is everybody okay with putting that one in?
Okay.
Okay. Policy issues. So for policy work, mental health clearly ranked high amongst those of you who participated. The next tier was pretty consistently at the higher end of the scale. That was rail safety, distracted driving, and electronic cigarettes. The 2 marijuana issues were pretty much consistently in the middle. And then the other 3 rankings for the sick leave for the dental provider and for tobacco legislation ranked from 1 to 9. So again, pretty all over the map. Didn't feel terribly consistent, so thought my recommendation is you seem pretty comfortable with leaving these on the agenda, and you might want to spend your time talking about these.
Can I wear my oral health hat for a minute?
You wear whichever hat you want.
I don't think I'm elected to that, but it is an important issue.
Well, we'll elect you right now.
Oh,
so
thank you.
Proceed.
Well, I think part of the problem with this mid-level dental provider issue is that most people don't understand what that's all about. And I'd like to keep it on, even though it might not be high up on everyone's agenda. Some recent statistics for all of you who may not be aware. We have a terrible problem right now with access to dental treatment for any Apple Health patient. So we have adult dental health in the state as a Medicaid or Apple Health insurance, but no one can access a dentist. And we signed up 70,000 people this year. None of those people can find a dentist. So this is a much bigger problem than most people are aware of. And this is a solution. It's not the only one. There's lots that will have to be pursued to find a solution for people who can't get access. So this is one, and that's the problem with it. It is only one, but it is one that's going to come in terms of legislation this year. And so I'd like to just leave it on there, even though it may not be high on all of your priorities. There is a big underlying issue here that's not being addressed.
Well, I think the understanding you just provided us, Keith, is extremely important, because I think that's the part of it where a misunderstanding of what it's about. I think you placed my emphasis a lot higher than it was 2 minutes ago in regards to what the problems are and what's happening. So I appreciate that. I'd be one to absolutely leave it down there.
Yeah.
After all, nothing ventured, nothing gained.
Yeah. John, did you?
So I would make a motion to accept your top level list.
Okay.
In blue, and add to it the mid-level dental provider as suggested by Keith, and then discuss the last 2 separately. But right now, have it be the blue and mid-level dental provider.
Okay, we can do that.
So I'll second for discussion, but I have, I guess, a comment.
Okay, let's have your comment.
So the rail safety one, which is up higher, when we spoke on the phone, I was not a fan of how you described it. So
I rewrote it. It's not in your packet, obviously, because I rewrote it since then, but the language is much more broad about just the general public health implications, but not being so specific about them being too rare.
Because I support under the category when it says policy issue and the potential legislation calling for the study of ability to respond to accidents, implementing, supporting, or reporting requirements, and implementing fines for spills. So that I supported. My concern that I shared with her was when you went under the description, and it says, of particular concern are diesel particulate emissions, which are linked to lung cancer and other health effects. And I explained to her, I said, well, you're implying that that rail is bad. And I said, we have an agricultural community here that relies heavily on the shipment of their products on a rail. And if we were to transfer all of those rail products to trucking, your diesel particulates significantly increase. And so I explained that I felt like while I could support the policy side asking for the reporting pieces, I didn't want the description to make it sound like we were advocating to do away with rail based on particulate emissions, when actually, if we moved all of our rail to trucking, that would be even worse. So I just felt like there's a disconnect in the description. I have not seen the new wording that she has.
And just, I see John kind of looking at pieces of paper. It's not a part of the description that's on your one-page sheet.
Why are we talking about it?
It was emailed out to us.
Okay.
Yeah, it's a part of the description about why this is relevant to public health. If you remember, there was a column for all of them. So that's not meant for public consumption, but I'm certainly willing to get the language to you.
So that's why I was saying I supported how it's written on this one. I did not support the rationale behind it because I felt like it was trying to move us away from rail. And rail is actually very important for our local agricultural community. So it's trying not to...
Yeah, I read that same thing and came with a wildly different conclusion than you did. I think we are considering the emissions and kind of in aggregate with the entire emissions that we have to deal with, whether it's wood burning, whether it's cars or diesel trucks. It's what they're just saying there, the way I read it was, we're just deeming that worthy of consideration. I don't read it as anti-rail.
Well, I read it as rail is, producing of particular concern are diesel particulate emissions, which are linked to lung cancer and other health effects. And I read that going, okay, well, if we move all rail over to trucking, that's even worse.
So how would you like it written so it's clarification?
She mentioned that she did the description. So I wanted to make sure that the description changed, because I supported what you were going after in the policy. I did not like how you described it, because I'm not going to advocate going away from rail.
Any other comments? There's a motion on the floor. All those in favor?
Aye.
All those against? Okay, thank you.
So the motion was to then further discuss the sick leave and tobacco? Okay. Comments on those?
I'll ask the question on the omnibus, the tobacco omnibus. Was most of the comment the fact that the one sentence in there for raising the minimum age to purchase to 21?
Nobody spelled out why they ranked it one way or another, but given previous comments here in our meetings, I'm guessing those who ranked it low, that might have been the reason. Yes. And my understanding currently, the planning around this legislation would be to separate that issue into a separate bill from all of the other issues related to tobacco.
Amber?
I think one of the reasons that I ranked that low was just that I read the comments that you had about, I was trying to use the funnel of our kind of what
the
are
criteria,
things we need to consider, and it sounded like there may be a lot of opposition. It may not have, again, everything's going to have opposition one way or another, but I got the sense from your graph that it may not be something that would be successful this session, and so for me, I think I ranked it lower, not the lowest, but just because when you looked at some of the other ones you had listed, there seemed to be a lot more chance of success. So that was where I was looking at that one.
Yeah, and that's the reason we're looking at pulling out the increase in the age to 21 to a separate bill, is we're getting definite voices out there that that is the most controversial piece. So they want to have that as standalone legislation, but then still feeling pretty good about the rest of the package, about raising the license fees and fines and those kinds of things. So.
Yeah, I would be supportive of that. I guess I don't have that in front of me to know when you pull that out, what are the other key elements, but I guess we'd have to wait and see if that gets pulled out for sure, how that evolves.
So I'd make a motion to include the tobacco omnibus legislation and just eliminate the sentence on raise the minimum age and keep everything else there. Noting that we have absent members that are on both sides of this issue.
I'll second it for discussion.
Okay, now discussion.
And we can always discuss that in January when we know what the legislation looks like, if you wanted to add that to your agenda or that kind of thing. So.
Keith?
Well, could I just say that when we do talk about that in the future, can we make it a much more knowledgeable discussion by looking at all the other age-related restrictions for things like Women are emancipated at 14 for many things, and other things you can't get till you're 25. So this age issue, we have to, I think, make some sense out of it rather than it being an emotional issue. If we could do that, please.
Sure, I can do some research for you. And I've also previously provided you a one-pager about the science and thinking around raising the age and some of the reasons that's being pursued. So,
Any further discussion? Okay. All those in favor?
Aye.
Those against? Okay, thank you.
so it's keeping the overall thing on the agenda, but removing just the age.
Just that one
Okay,
sentence.
we'll come back to that. Okay. Sick leave.
I don't think there's enough information in there for me to be able to decide whether I support it or not. I just felt like it was very vague. And I realize that some of that information will come out in the legislative session, but some of those key pieces of information, I need to know where they're leaning before I can decide whether I could support it or not. So at this point, I would rather leave this one off.
And I believe when we talked, it was a lot of concern about not knowing the detail and what costs might be,
Correct.
as opposed to not necessarily being against the public health perspective of what sick leave provides. Is that correct?
I just looked at as what are the cost implications? Does this include temporary employees? So am I suddenly going to have to provide health care for the county and the city? We hire a lot of summer temporary employees. Does that include them? And then if so, what's the cost implication, and how many people do I not get to hire? Do I have to lay off to cover that mandated cost now? So I didn't know enough details behind what they're looking at doing to be able to support it. So I can't support it this time.
We're having a conversation between Shelley and
I know. I'm sorry for
John.
that.
I didn't know what the fiscal note behind this was. That's my issue.
So I think those are important concerns. I've been in discussions with local businesses about this policy. City of Spokane could potentially be considering doing something like this. We're now seeing several years in from many cities around the country about how this has affected both public health and particularly small businesses. And we're seeing some really encouraging results, that it's not only not really hurting small businesses, but having sick, and it's really important to emphasize, and safely. We're talking about really for folks that are victims of domestic violence who have no other recourse than to choose between their families and their jobs at very critical, traumatic situations, that this is what this policy is for. Amber, Shelley, and I have all been part of that domestic violence discussion here in Spokane County, and to me this is an essential piece of that puzzle. But just like we did with tobacco, I think maybe we could address some of these concerns by just rewording this a little bit. It says right now, support legislation to require employers with more than 4 full-time equivalent employees. That's a very low bar, and I even think that's lower than a lot of the cities have out there, and it's certainly not something that I think is prudent. If we could just get rid of that and just, I think if we support legislation to require employers to provide paid and sick and safe leave and not say that level, because it may be the kind of thing that just really more starts at a higher level. 4 is just really pretty small.
I think the implications, however, are there, the perception. I think I agree with you, Shelley. If we're going to go for it, I think we need to have more detail of what we're looking at before we go forth with this. Here again, there's probably many things that are happening within that field as we speak, and so I'm really concerned that we would simply be that general until we know what's happening.
You know what I'd find really interesting is before we took this on as a board, because it is going to be fairly controversial, I would love to have a presentation done on maybe model cities. I know there's cities that have passed this with legislation written in a way that we would support, or that maybe the city of Spokane's looking at, that have been doing this for a couple of years to see what those outcomes are. I would like to see, I mean, it's not like we're reinventing the wheel here. So what have been the outcomes a couple years later on some of these cities that have pursued the legislation?
Well, John seems to have a pretty good background on who he's working with. Maybe you can set that up for us.
I mean, I think it would be interesting if this is something we're actively going to support without details. I would think I'd want to know what we're supporting then.
I don't know. To me, it's pretty clear. To me, it's just a matter of threshold, kind of the same as the tobacco legislation. I'd be happy to help work with health district employees to get us that in the 2015 meeting. But I still support keeping it on the agenda, even if we have to change the language in a way that makes it more palatable for folks, because I think it signals a desire for this issue to be worked on, and I think it's a really important issue.
Okay,
I think
let's do that then. That's so we can move on. How would you like it worded?
No, I can't see leaving it generic though. To me, leaves that open to requiring I mean, if we say we're supporting it, and then the legislature goes forward with 4 full-time equivalent employees, we've made it so generic that we would support that, yet I still don't have a fiscal note tied to it. So I just would have a hard time. I want to know what the implications are, both to the county and to our local small businesses.
So
I need more information.
So couldn't
on
we
this.
bring this up at a later date?
Well, or it's also
I have a
possible
motion
to
I'd like
have
to-
it on. Go ahead.
Let me try to make a motion.
Actually, Keith had his hand up, and sorry.
All right, so here.
Which hand did you have up? Because I can't tell. One you're half asleep.
So I'm going to push the button.
Do you mind if I make my motion? Okay, so the motion I would make is to change the language to say, support legislation that would encourage employers to provide paid employee leave for employees, and then keep the rest as it is. That would be my motion. Gets rid of the required, gets rid of the threshold.
I'll second.
Okay, further discussion? Now, Keith, you have your turn.
Well, I was going to say, I support it. I would support keeping it in front of us for the reasons that are listed there without specifics like the threshold and all that, because that's not what's interesting right now. The interesting part is that we would support something from a public health standpoint for these 3 reasons, and I don't see any reason why we wouldn't do that. The specifics are going to come in what gets proposed, and then we can decide, or we're going to have to decide if we want to support it or not. I don't think we can decide that in advance.
But we're not. See, that's what the problem is it doesn't necessarily. By passing this, we're sending Linda out to go and advocate on behalf of us without details. So
no, for these 3 reasons.
Those are pretty clear.
Right,
These
but when the legislation becomes, I mean, I would be more comfortable on this one when legislation detailing the details of what we're actually requiring employers to do is available.
No,
right now I don't have that, and so
I understand that. I'm just saying that I'm willing to support these 3 reasons for why we would want to keep our ears open for this issue to come to the table.
Okay.
And that's definitely.
Does anybody want to call for the question?
I'll do that. I'll call for the question.
Okay. All those in favor of the motion?
Aye.
Those against?
Opposed.
Let's count them.
Aye.
Ayes? 3. Those against? 3. It's no.
I'm sorry. What was the outcome?
No, it's voted down. I mean, it's a no vote. It's tied.
You didn't break the tie.
No.
Wait, how says
3-3, isn't it?
It wasn't a tie.
Oh, Susan, what'd you do?
I voted in favor.
Oh, okay, it's 4-3, I'm sorry.
Nice try.
I can't see.
Oh, well.
Just for clarification.
We wanted you to break a tie, but there wasn't one.
For clarification.
Okay, then to continue this live.
Chuck,
yes.
For clarification, the motion though is with the changed wording.
Absolutely.
Yes, and I did get that, and if I didn't capture it correctly, please correct it next time. And just so you know, part of my role during session is to come back with those details and talk those through with everybody and figure out then what's the messaging back to the legislature. We support this in general, but So that's a possibility.
So I feel like with this now, Shelley put me up to following through now, and I'll be happy to share my research with
Yes,
you.
I did. You have homework.
Put my
We'll be
put some
talking,
work
I'm
into
sure.
that.
Okay,
Yeah.
so John will help you.
All right. And just so everybody, in case you forgot, there is a one-pager that gives you kind of some overview about the paid and safe sick leave provisions, and then John and I will work together and bring you back some more.
Okay. Anything else?
I think we're good.
Any questions you want to talk to Linda about while you're up? And Susan, yell at me because for some reason I can't see you. If you got your hand up or whatever. I didn't mean to ignore your votes at all. Okay, thank you. Okay, let's go to item number 7, please, the consent agenda. Do I hear a motion to accept the minutes of October 30, 2014 and the vouchers October 1 through 31, 2014?
Move approval of the consent agenda.
Second? Any discussion? All those in favor signify by aye.
Aye.
All those against? Okay, thank you very much. Now, the next 2 items are extremely important. We have the 215 chair election. There was nominations, if you recall, the last meeting. So I would like to have a motion to select Chuck Hafner as the chair for next year.
Second.
All those in favor?
Aye.
All those against? Okay.
Did you vote for yourself, Chuck?
All right. And we also have to elect the 2015 vice chair, and that is
You, according to the agenda.
Yeah. I was just simply going to say, I'm not going to do both of them.
I would move that we appoint Kevin Freeman for vice chair for
Okay.
2015.
All those in favor?
Wait, we can do a second.
All those in favor?
Aye.
Okay. All those against? Thank you. Congratulations, Kevin. Report. Susan, public health emergency preparedness, please.
All right. Uh-oh. All right. Thank you and good afternoon. I get to be in front of you 2 board meetings in a row, and I appreciate that. Last month we talked about healthcare system preparedness and our role as regional lead for the Healthcare Coalition for Region 9. And today I'm going to talk with you briefly about public health preparedness, specifically our agency, and toward the end of it, really the role of the board in supporting public health preparedness. So I thought I'd just start by going down the list of what are the hazards that we as a community face and what the role of public health might be in those. We participate with a huge number of partners across Spokane County and the greater region of eastern Washington. And it's wildfire, winter storms, extreme heat, hazardous material incidents or a train derailment concern. Certainly communicable disease outbreak is one area where public health is front and center. Terrorist biological incidents, earthquake is now on our list, and any type of incident that would cause multiple casualties or fatalities where we'd be supporting our partners. So as public health, we're really charged by the Centers for Disease Control and Prevention and Health and Human Services around preparing in the form of capabilities. There are 15 public health capabilities that have been identified, and most of them, and I apologize the light in here isn't great for the color of this infographic, but most of those capabilities are represented by one of the pictures in this area, but they're really in 5 main arenas. The medical surge coordination, that's both the Healthcare Coalition piece as well as supporting medical needs sheltering or med surge from a public health standing up of an alternate care facility. Certainly communications in all types of hazards. Public health has a role for messaging to our public, to our partners, and internally. We have all the responsibility related to mass dispensing and mass vaccination in terms of leading that effort.
We operate through emergency operations, and then fundamental public health work in disease investigation, surveillance. And testing is still on this because our lab was open at the time that we created the infographic, and it hasn't been updated. From FEMA on down, though, the whole entire preparedness cycle is based on quality improvement. The circle in the middle likely looks very familiar to most of you around our agency's activities related to ongoing continuous improvement and quality improvement. And the PREPA program, the preparedness program, has that has been fundamental to that since its inception from the feds on down, that we're constantly evaluating, improving plans, testing those plans, and the cycle goes on. When our preparedness planning started post, really the infusion of money post 9/11 and the anthrax letter issues that happened shortly thereafter, we focused across the nation, including in our own community, on making hazard-specific plans. We had massive plans as directed by the feds for smallpox and for anthrax specifically and for pandemic influenza. They were huge plans, lots of redundancy, very difficult to work with, learn, exercise. And so around 2007, across public health, we really began to move toward an all hazards approach, which was really finally listening to our well-seasoned partners in fire, law enforcement, our traditional first response communities, knowing that there's more commonalities to every incident than there are differences. So let's plan that way, and let's pay attention to those areas where we might have differences. There do remain unique considerations, though, for specific hazards. And so part of our planning, we now have one emergency response plan with multiple appendices for lots of different things, but we are now including hazard-specific appendices so that we can really address, are there uniquenesses for public health's response to support whatever's happening? What are those response actions? What are the specific health impacts to our population? Are there high-risk populations that we need to be paying closer attention to than others? Our public messaging and trying to predetermine as much of that in advance as possible so that we're not having to do volumes of that on the fly. What's the safety to staff, our own staff, in terms of what we're expecting of them in a response? And then what are the unique resources or other special considerations so that we have as much of it mapped out, which is the whole part of planning, in advance, but we're still basing it on one fundamental plan. So when we look at the emergency response plan, which is really our guiding document for responding to things out in the community, it covers our legal authorities as an agency, the health officer's legal authorities, and the role that the board plays, roles and responsibilities, how our notification and activation process happens internally and from outside partners, the resources we need to put our fingers on, and then what our specific response actions are going to be, again, related to that infographic and all those different capabilities, communications, disease surveillance, environmental public health, vital records, etc. So I've said that we have one emergency response plan, which is our main plan, but by combining that into an all hazards approach, we've actually been able to focus on additional plans that help really detail operationally what we need to do as public health in a response. And there's a bunch listed here, but we have a specific risk and emergency communications plan that it's not only when we have an incident, but we can turn to that plan for preparatory actions. We've used it just recently around communicating with our most vulnerable populations to address their concerns around Ebola. And we've got lots of information around who those vulnerable populations are, how we access them, who their gatekeepers are, and who do they listen to. And then we provide the information to them to get out to their communities. So that's one use of that plan on a routine basis. We have a mass treatment plan. It used to be just Spokane Regional Health District, but we have 10 counties in our region for which we serve as the lead agency, and we've now regionalized that plan so that any of our public health partners across these 10 counties could help each other out for a mass dispensing, mass vaccination type of an event and be very familiar with what's in each other's plans. A non-pharmaceutical intervention plan, which you would most likely recognize as isolation and quarantine plan, but that's really only one aspect of an entire continuum of non-pharmaceutical interventions for disease mitigation. We have an alternate care facility plan to help decompress the healthcare system and hospitals. And then we have a public health emergency resource coordination plan that really helps us call on each other as public health across the region to help. It's really less, though, about the plans and more about the planning. I don't know that any of us in an actual incident, at least within the first 24 to 48 hours, go to the plan immediately. But what we rely on was the planning process, the relationships that we've built and the partnerships, the fact that we've worked through protocols and processes in advance and have at least a good understanding, if not a specific understanding of what that needs to look like for a response. And so it's great that we have all the different plans, but what's really great is how we work with all the partners to help response happen. But because we have all of these plans, not only ours, but all of our partners that we want to have as reference, one of my team members early on, Patty Richards, had this brilliant idea of setting it up in a dashboard. So if you ever have an opportunity to get into our emergency response plan on the internet for the health district, this is the main page that you'll come to. And each of these areas will allow us to quickly get to all those resources that we've spent a lot of time developing and identifying and processes. Agreements, phone numbers, pretty much everything is here and accessible by this dashboard, and it's been a saving grace for us to have it organized this way. There are a lot of other plans across the community, and as Spokane, there isn't another community I'd really like to be part of if we have to face a disaster. We're incredibly well integrated as a community across all the disciplines and partners. It might not always seem that way because we're also all strongly opinionated and lots of expertise is shared. But when push comes to shove, this community is amazing in coming together, and I'm happy to be part of that. But we also have a role in helping plans that aren't our specific responsibility, but helping making those processes move forward. We were one of the first areas in the entire state to have a behavioral health disaster response plan, facilitated by Public Health and the Healthcare Coalition. It's owned by the RSN and Frontier Behavioral Health, and they're really centered to that plan, but helping that process happen was a role that we played. Family Assistance Center planning, any kind of multi-casualty or specifically mass fatality incident, it's our role to figure out how we support the families. And this Family Assistance Center plan effort's been led by Cindy Thompson and done an amazing job of pulling that need together that was identified by our medical examiner and all of our first response partners, that we can handle the fact that there's fatalities. We don't have any idea what to do with families and how to support those families through such a tragic event. So that plan is now in its final draft and will be exercised in March of this coming year. We participate in the city-county emergency management plan, the CEMP. We have a section of that in Emergency Support Function 8. And then we also have the Disaster Medical Coordination Center as part of our responsibility of how forward movement of patients between healthcare facilities. So when do we respond? Obviously, when it's a communicable disease event, public health is front and center. Ebola has been the most current and still. 2009 H1N1 pandemic. SARS before that. Those were all public health center, and so lots of our first response partners actually came to us to support the effort versus us going to their operations to support one small portion of messaging or some other aspect. We have a role in lots of different types of events, a medical surge event that really involves the hospitals. Dr. Joel is a key person in consulting and seeking consultation with our hospitals and EMS and fire medical examiners on the appropriate types of treatment or prophylaxis or mitigation measures. In a mass casualty or fatality, I mentioned that we would have a role in helping coordinate the Family Assistance Center. We're one of 4 organizations named to help lead and set up a Family Assistance Center. The health officers' authorities may be called upon. Vital Records plays a role. We have a small-scale call center that could be activated. Disease investigation is usually part of it. And Dr. Joel's role as a physician in being able to sign death certificates for fatalities that the medical examiner passes off. That's not the right word. I don't know the word. To the health officer to have that opportunity where the medical examiner doesn't have to have jurisdiction. And then in mass care, we have an amazing Red Cross in our area that provides mass sheltering across most of eastern Washington, North Idaho. And they share with us their EPI reports for monitoring the health of the people in the shelter. And we participate in that. And we've also been able to develop a unique model. I'm actually presenting at a national conference next week about the co-location of medical needs sheltering with general population shelters. We're tasked occasionally, or could be tasked, with having an alternate care facility that provides medical services for low acuity patients. But we're not great at the business. We could be, I guess, if we had to be, but we don't have to be because Red Cross is great at the business of sheltering, feeding people, providing showers and medications and all the things that they do amazingly well as sheltering. So we've actually entered into a joint agreement with them to be able to have half of the shelter become a medical needs shelter. If somebody on the general population side needed additional medical assistance, but not to the level that an emergency room or a hospital stay was necessary at that point. So it helps preserve those services to the right level of care and provide an intermediate step. So, what's the role of the Board of Health in helping support all of this activity?
We knew that was coming.
Yes, and I think it was probably supposed to be the focus, but I think Michelle needs to do most of the focus around the legal aspects of it. But practically speaking, part of the role in supporting all of this preparedness is really being able to participate, so I wish I had a little pointer, participate in drills and exercises that we might do as a health district, something as simple as the secures call down drills in response to being able to push out information quickly to you. And exercise is always an invitation to participate in any kind of tabletop or functional exercise that we're hosting. The release of emergency funds to support a response is a clear role of the board. Being able to support Dr. Joel in disease mitigation decisions, that whole continuum of non-pharmaceutical interventions. What does social distancing look like? And what does it mean to have people not go to the movie theater or whatever if that were to come down? Those decisions are decisions as a health officer that he's going to be able to make with your support and conversation. And then specifically, your role as board in communicating out to your own constituents, being able to give the message in preparedness times before an event, but also using cell phones, Twitter, that little bird is tweeting, those types of whatever mediums to get communication out to your constituents about what we might be asking them to do to protect their health as an incident is unfolding. So those are all really clear roles and important steps for our board, you, to be able to have with us as we're trying to mount a response that public health is center in. These are the references of the RCWs and WACs that support those previous pictures. And a couple of years ago, I'm going to put Michelle on the spot, she did a great presentation to the board around the specifics around the legalities and how that actually plays out, and that might be something of interest to follow on sometime in 2015. And then the last piece that really gets it back out to the broader community is there's two groups in our community that many of you may already serve on or have representation on. The first is the Emergency Management Policy Group, and that's made up of the sheriff, who's our emergency manager for Spokane County, and his deputy, Ed Lewis. But it also has representation from county commissioners, each of the city of Spokane Valley and city of Spokane, lead fire people, the police chief, Dr. McCullough, around policy decisions, around preparedness and response. The second is a group that really takes their direction from the policy group, and that's the Emergency Management Operations Group. Dr. Joel also serves on that, but for that one he's able to appoint me to represent, because it's really the working group of how to implement the direction around planning, training, and exercise across the whole community and how we coordinate that. So I think that's uneventfully the end of my presentation. Questions?
Good report. Any questions you may have?
I thought I had it in my head here. Let me rethink it. Susan, I understand all the hard work you've done and all the people do around emergency situations. I'm struggling a little bit with the interface with things that go on sort of on a chronic basis, like STDs. It just seems like we never get a handle on that. It's not a true emergency, but it's almost like a communicable disease issue, something. I'm just throwing that.
Right.
What's the fine line between what is classified as an emergency versus some ongoing sort of process that's dealt with in a different way?
Well, I'll take a stab at it, and then I'll look to some of our executive leadership in the office. No, but I think it's the urgency with which something is needing to be addressed, not suggesting that STDs and HIV as chronic illnesses aren't urgent, but it's that life safety, immediate life safety, I think, is for me what is in my head around where preparedness and all of our preparation and response happens around emergent communicable disease issues and life safety, and chronic issues that take a much bigger planning piece and interventions.
So if something became a crisis, then it might fall into
a crisis with work. Yes, it could a crisis with time-sensitive response.
Okay.
Dr. Joel, is that fair?
Like kids dying of measles would become a crisis and therefore fall into this
absolutely
category. Okay. Mm-hmm. I think I understand.
Any other questions?
Also, to provide additional perspectives, that we're dealing with regular disease situations all the time, not just the STDs, but we're also dealing with outbreak situations on a regular basis, which may not rise to the media attention because we're able to control most of them through appropriate action.
Okay, let's see, we're down to the board member check-in, please. Susan, anything?
Nothing from me.
Do you still have something to say?
I know I do. I just want to.
I don't know how I'm going to shut him up.
I just wanted to thank Mayor Freeman and Councilmember Hafner for taking the leadership role for next year. It's hard when you're in a city that's not the city of Spokane or the county, because you're coming from a farther direction, and you're also getting double the pay, which is zero. And I just want to say I really appreciate both of you stepping up to this important leadership responsibility.
Okay. We thank you very much for that. Council Chair.
I'm just looking forward to our next strategic plan meeting on the 8th.
Shelley.
But you went out of order.
I know, that's all right.
Oh. Well, since John and I have been talking, I needed to.
Screw you up and get you out of order occasionally, so.
No,
I don't have anything.
And he went back.
Tea?
No.
You skipped me.
Aren't you going to let her talk?
Come on, Chuck.
No, looky,
This
we
is
just
our
have fun and games together, so that's all right. Okay, Shelley, now.
Now it's my turn. Okay.
Okay.
No, it's our last meeting before the end of the year, and so I just want to wish everyone Merry Christmas, Happy Holidays, as we go into a very busy season. I know our calendars are all full, so enjoy it with your family and friends.
I do have a favor, everybody in the audience, please. I would like to have you all stand for just a moment. Everybody has it. That's a board too. Come on, Ann. Oh, I'll stand. Now, I have the privilege and the pleasure of being Santa Claus this Saturday for about 300 or 400 kids. Okay. Now, my colleagues have told me that my ho, ho, ho is not right to get it out. So I need your help. So what I'd like you to do, when I say 1, 2, 3, I want all of you to say a ho, ho, ho. Now let your diaphragm come out all that way it's supposed to. But when I say 1, 2, 3, I'd like to hear you say a ho, ho, ho. Okay? 1, 2, 3. Ho, ho, ho. Okay, now I'll remember that Saturday morning. And with that, I'd like to say Merry Christmas, Happy Holidays, and a Happy New Year. Thank you very much.
Thank you.